Yo, yo, yo. Hey guys, welcome back to another amazing edition of the Best Practices Show podcast. It is Friday, and you know what that means? It means two things. I hope you've had a great week, and if you're tuning in today, you know every Friday our job is to keep you at the top of your clinical edge with some thinking from some of the top thought leaders in all of dentistry. And there's a big conversation going on right now in dentistry around MARPEs, mini screw assisted rapid palatal expanders. And there's nobody better to talk about what's happening in that conversation than Dr. Becca Bockow. She's brilliant. And today we have her on the podcast. So please listen up. I hope you guys enjoy this, and we'll see you soon. Hey guys, welcome back to the Best Practices Show podcast. I have the coolest job in the world. You know what I get to do? I get to interview incredible rock stars in this amazing profession called dentistry, and they get to share insight, information, new thinking on some of the things that'll make your practice and your life better. And when we talk about these people, one of these people, she's a rock star, one of the coolest people in all of dentistry, a regular member of the ACT Dental community, and I have her on today. Her name is Becca Bockow. And if you don't know who Becca Bockow is, what have you been doing? You've been living under a rock? So, Becca, thanks for being back. I always appreciate you.
Thank you. Thank you for having me. Thank you for all you're doing for us in dentistry, truly.
Well, I appreciate you being on, and you guys don't know this because behind the scenes, I try to schedule all these things, and I've screwed up a lot in the last few weeks, and Becca's had to reschedule. So I'm so happy to have you back on, and finally, we've got an amazing topic today. There's a super hot topic in dentistry called MARPEs, and let's talk about what's happening in the world of MARPEs. Maybe give us the big picture here. Wait, no.
Sure.
Wait. I'm going to change my mind. Because we have so many new and young listeners, we actually have dental students listening now. I want them to know who you are before we get into that. So tell us, who's Becca Bockow? What do you do?
Sure. Great. And maybe I can lead into why this matters. So I'm a dual certified orthodontist periodontist. Before I went back to school, I practiced restorative dentistry in Seattle, Washington, and I was a big fan of dental CE. I was a CE junkie, and ultimately decided to go back to school and was really involved in interdisciplinary dentistry early on, and thought if I can be part of the interdisciplinary team and set the foundation. Well, let me back. As a restorative dentist, a lot of the breakdown I saw had to do with the foundation. The teeth were in the wrong place, and there was a lot of dental breakdown. So you can't do a veneer, for example, on a patient with a deep bite. They cracked their front teeth. Where are you going to put your veneer? So I thought if I could help set up the foundation for the interdisciplinary team, I'd be doing my patients a service. I learned that there was a combined perio-ortho program at Penn, and I thought that was my end goal. So it was very lucky to be part of the UPenn program. I did both programs. I'm dual certified in periodontics and orthodontics, came back to Seattle and started my practice. Around that time, 2013, we started learning more about Airway. And a lot of our training had to do with early expansion to make sure that the teeth are centered in the bone to prevent gum recession. That was a big part of our program. So early expansion, teenage expansion, adult expansion, because ultimately, if you push a tooth out of the bone, that's where you have instability in terms of dental shape and form, and also instability at a periodontal level. So now, fast forward 2013, I had a chance to listen to Jeff Rouse, and he's showing case after case of these adults with sleep apnea. And I'm sitting in the front row, and I thought, these are all orthodontic patients. These are all patients that have a skeletal discrepancy. And if we think back about it, if we take a big step backwards, if we think about sleep apnea, it's a constriction of nasal breathing and or a lack of tongue space, which ultimately leads to airway collapse, either at the nose or in the back of the throat. So if we can expand, we influence the airway in the following ways. The roof of the mouth is the floor of the nose. So as we widen the upper jaw, we improve nasal breathing, which reduces negative pressure in the system and reduces collapsibility in the back of the throat. So resistance here leads to collapsibility here. And as you widen the palate, you create more tongue space, further reducing collapsibility in the back of the throat. So expansion, both at young ages and at older patients, has a tremendous positive impact on the airway. And so I became very involved in early expansion for a number of reasons. And so as we got more and more into this, especially in our residency program, so now I'll give you a history of expanders. So that's me. That's where I came from.
Love it.
And so I'm an orthodontist, but I'm an orthodontist with an eye for the periodontal health. And I'm very interested in airway and sleep. And I very much care about dental shape and form and ultimately creating stability in the system, which leads to aesthetics, which leads to long-term patient satisfaction, et cetera. So historically, we had adolescent expansion. So 5, 6, 7, 8, 9, 10, great, all the way up into early teens. Once we get into the teenage years, if we think about this, we're trying to influence a sutural system. So the bones in the head, they are a series of bony plates and they meet at sutures. A suture is a site that responds to pressure. And so in a young child, 7-year-old, 8-year-old, if we glue something to the upper teeth and we slowly turn, we are widening the maxillary suture, as well as some of the surrounding sutures. As we as humans age, the sutural system gets more intertwined and more mature. And so if we use a tooth-borne appliance on a skeletally mature patient, we inadvertently push the teeth out of the bone rather than opening the suture. So historically, we would have tooth-borne expanders, and then we would have to jump to a surgically assisted expander, meaning we have the same appliance glued to the teeth. When the bone no longer can change, we would send the patient to the oral surgeon, and the surgeon would cut the bone, and then we would do our expansion. So the big innovation in our world came with TAD-supported expanders. And we've been using them since about 2007, 2008 at the University of Pennsylvania. A lot of these initiatives were led by Dr. Mariana Evans in our program. And we've evolved over the years. So, gosh, it's 2025. So we've been doing this for some time, and we've had a lot of failures along the way. We've learned a lot along the way. And that's what I'm really excited to talk about today is where are we in this journey?
Yeah. I think a good place to start, even for our young listeners, is define MARPE. Like what does it stand for? Why is it so important in your work?
Yes. So take this. So once we reach this age of, once we start seeing the adult dentition and we start thinking about more skeletal maturation, that's around the time when we have to think that a tooth-borne appliance to widen the upper jaw has the possibility of seeing more dental change and less skeletal change. When we think about our final outcome, we want to actually widen the upper jaw. So the innovation is to use mini screws and anchor the expander to the bone itself. So MARPE stands for mini screw assisted rapid palatal expander, MARPE. And we use an expander and we add TADs, temporary anchorage devices, underneath the expander itself, so that as we turn it, we're actually widening the upper jaw. We're widening the bone, not moving the teeth through the bone.
Yeah.
So we prevent gum recession, we widen the nasal floor, and we're avoiding surgery.
Yeah. Now, this is not without controversy. Everybody, everything. Everybody has opinions on this, but it's so fun to watch you learn and teach this stuff. One of the questions that comes up is like, let's talk age groups. Let's talk specifically. Give us your thought on what age group are we talking about specifically?
And so, Kirk, this is really exciting because this is where the needle keeps moving as we get better and better at this. So back to when we first got into this, our TAD expanders, it used to be most predictable from teenagers probably to in their 20s. And it was great. But once we got past, let's say, age 25, we would have to do a TAD expander and we would combine it with a surgery. So we'd still add the TAD expander, but we would ask the surgeon to cut the upper jaw and to cut in between the front teeth. And then as we turn it, we're still getting that widening, but it was an outpatient surgery. Today, what I'm really excited to talk about are some of our advances that have taken away our need for additional surgeries in many instances.
Yeah. Well, let's go there. Let's talk about some of those advances. Also, can I just ask, like, gender? Does gender play a role in any of this?
So going back to our evolution, where we've come from, the 2014, I think, was the first time I took a course on the MSC, the maxillary skeletal expander. And that was really popular. It's still a quite popular TAD expander, MARPE brand. It's a brand. And it was great, but it had its shortcomings. And so Dr. Audrey Yoon published an article in 2022 showing that it has a high failure rate, an MSC. It fails about 17%, 18% in adult females and 67.7% in adult males over the age of 25.
Why?
That's a really high failure rate.
Yeah.
Adult male bone is dense, and as we would turn the appliance, any of the following would happen. The TADs would bend, the jack screw itself would break, or a combination. And so the appliance would tip, but we would never see the suture open. And I've had failures in my own practice. Of course, you never start your treatment plan thinking that that's going to be the patient that it doesn't work. So we started doing more and more surgical interventions in combination with the MARPE, the MSC specifically, to avoid these failures. Actually, I have one. Hold on.
Show it.
I forgot I had one here. Give me a sec here.
Yeah.
So I'll show you why they failed and how we do things differently. And that'll really help us understand the evolution. So this is one that hasn't been made for a patient, but I'll show the listeners, for anyone that's watching. Can you see that there?
Yep.
So this is an MSC. We bend this. So this would go up into the roof of the mouth. And then the 4 TADs would go in these little holes. Let me see there. You can kind of see it there.
Yep.
So these 4 little holes. Now this is a stock appliance, meaning this comes standard and it's one size is designed to fit everybody. And so you bend this up, you fit the bands on the patient, the bands go on the teeth, and then as we turn this, it opens up. So the shortcomings here are the following. This has to fit in the roof of the mouth of a standard patient. Now, some of these patients that we're expanding, their palate is very narrow. And so case selection alone, there's certain patients we couldn't fit it in. Also, it only has a certain width. It can only go, this particular one is an 8 millimeter, so it can only widen 8 millimeters. Let's say we wanted 11 or 12. You can't get it. You can't get it. The jack screw itself, not the strongest. And then one of the biggest problems with it is it It has predetermined holes. So we can't decide as a clinician where the TADs are going to go. We can determine where they're going to go anterior posteriorly, but they have to go straight up, and that's it. And so when I was doing audits of my own patients and very closely looking at our failures, Kirk, one of the things I was seeing is that even though we went straight up with our TAD, if now patient anatomy is anomalous, that's the beauty.
Right.
We're all anomalous. And so sometimes, even though the suture's straight in the mouth, in the CBCT, the vomer, the bone that goes in the middle of the nose, might divert to one side. So the TAD goes straight in. If it catches part of that bone, now it's a solid anchor. You turn the expander, only one side moves. That's a failure. And so it wasn't customizable. So the reason why this has a high failure rate is stock appliance, wide, it can't fit in the roof of the mouth. You can't custom design where the TADs are going to go. The jack screw itself is not as strong, as well as maybe a few other reasons. So it was the best we had.
Right.
And it was good, but 67.7% failure without surgery, that's high.
Very.
And so, can I show you where we are now?
Please. And give us the story behind it. I want to hear the story behind it too.
Yes. Well, so a huge shout out goes to our lab partners. So Partners Dental Studio has been at the forefront of designing these appliances. And so they said, look, we can digitally design where implants are going to go today. A lot of implant surgeons today are doing guided implant placement. They take a CBCT, they have a library of the implant, and then they design where the implant's going to go, and the lab designs the guide. Why can't we do that with TAD expanders?
Right.
And so they developed a software program to custom design where the TADs are going to go for that specific patient. And that right there was a game changer. Then, so they're able to handpick where the TADs are going to go for that patient. And then they can 3D print, 3D mill a custom substructure. And so we can not only can we decide where the TADs are going to go, but we can decide how many TADs. So we're learning that the more TADs we use, the higher the degree of predictability. So custom design, custom TAD placement, stronger jack screw, and more TADs. So I'll show you, here's just one patient coming in a few weeks. And so I'll highlight what's unique here.
Yeah.
So you can see we've custom designed, this can go into a narrow palate. We have 4 TADs per side. Each TAD is custom chosen where it's going to engage the bone. And the jack screw here is incredibly strong, and everything is 3D printed. So very customizable. And so what we've been able to do is dramatically increase our predictability, and we've been able to reduce our complications, and we've been able to reduce the amount of surgery.
Yeah. How much, take us back in time. So how long have you been doing this?
Oh, few years.
Yeah.
A few years. And so even in the last few years, we've evolved. So when I first took the MSc course, I want to say they taught us 4 turns in the morning, 4 turns at night, every day. And we were seeing failures left and right.
Wow.
So then we thought, well, let's slow it down to 2 turns a day, 1 turn morning, 1 turn night. Then we slowed it down to 1 turn a day. And every time we slowed it down, our complications went down. And so now, Kirk, we're sometimes doing 1 or 2 turns a week.
Wow.
And so as our technology has evolved and as we've critically watched our cases, our protocols are changing. So we're seeing less failures. because of how we're utilizing the appliance as well.
Yeah. I have so many questions. Talk about the recovery process for this.
Yes. So pain is so variable. Experience is so variable. For the most part, it's 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 4 puncture wounds or 6 or 8 puncture wounds in the roof of the mouth. It's not super painful, but hopefully it's Advil Tylenol range of discomfort. Because some of these TADs are very long, 15 plus millimeters, they can feel kind of sore for a few days. It's rare, but some patients feel some soreness, but it doesn't last more than a few days. When patients turn, the turns themselves are small. And so they feel pressure, but the pressure sensation goes away after a few seconds.
It's amazing. And then, when you ultimately look at this, you're more predictability, less surgical intervention. And you work with one of the best surgeons anywhere. I'd love for you to talk about that and talk about your research on your side. Like, what kind of results do you see predictably now more with this process?
So our oldest patient to date has been 66 with no surgery. So age is no longer an impediment to this procedure. We have successfully, now, if you think about the sutural system, there's a suture here, 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 and in the roof of the mouth. That's the whole nasomaxillary complex. And so if we can widen, chances are we've opened up all those sutures. So now we can combine it with a face mask. We've corrected underbites. We've corrected open bites. We can leverage the skeletal anchorage to accomplish movements that historically had to be a more complex surgical intervention. Now, this doesn't take the place of jaw surgery, but it can solve problems for some patients less invasively in a very predictable way.
Absolutely.
And that's been really exciting.
Yeah. I always say this. There are people that fix teeth or straighten teeth, and then there are people that change lives. You're totally changing lives in this whole process. I do want to talk like what you spend your extra time, like whatever extra time you're an incredible educator. When you talk about what's happening in the world of MARPEs, what do people most get wrong about this concept? It's maybe a thought process or a limiting belief. Anything come to mind?
Yeah, a few things. First, I think the general public is excited about it and they think it's a panacea. So we can widen the jaw, we can bring the jaw forward, and we can intrude with a reasonable degree of predictability. Widening for sure. Some patients are great candidates for MARPEs. Some, the true diagnosis really is a maxillomandibular problem, and some of them really need jaw surgery. So we have patients that come to us and they say, I need a MARPE. And I say, well, you actually need double jaw surgery. Or you need to see a sleep physician. You need to see an ENT. A MARPE won't fix it. And so I think as a profession, we need to understand where its place is, what its purpose is, and if we're chasing something like sleep apnea, to remember that as dentists, as dental professionals, we're part of an interdisciplinary team. And no one person, no one intervention can guarantee resolution of such a complex medical issue.
Yeah. You're privy to a lot of people that are very influential in the industry and technology. Like, talk about the evolution of technology, what you hope to see in the future, or what you like. I want you to predict the future. What's the future of MARPEs look like? If you had to, it's anyone's guess, but.
I think we're getting better and better with our designs. I think those of us that are using it in a high volume, I think the more research we get behind these, I think we'll have a better understanding of predictability, case type. I think we don't have a uniform agreement on where to place the TADs, the angle to place the TADs, the turning regimen. There's some people that do multiple turns forward, multiple turns back, and then the next day they do a few more turns forward, but still same number back, and then a few more, and then a few more back. And so having a standardization of a turning protocol, having a standardization of number of TADs, where to place the TADs, or just an understanding of where and how they're failing. One of the other key areas that we see is some patients have asymmetrical expansion. And so understanding why. Why is it that we sometimes see the upper jaw start to develop an asymmetry as we turn? That's a very big problem. So let me explain what that means. We're turning, and then all of a sudden one side might bow up. That we have to abort. We have to stop turning because we don't want one whole side of the face to bow up. So how do we catch them early? Well, first of all, how do we prevent it? If we can't prevent it, how do we catch it early, and how do we fix it before it becomes a big problem?
Right.
And so these are all pieces that we have been solving in our practice. For example, our slower turning protocols are very careful design work, and then we monitor our patients weekly, even when we're doing 1 to 2 turns a week.
Yeah.
So very careful monitoring.
That's so cool. And then just because you have the perio background, just talk about the long-term implications of the health of the bone, and you get to see a lot of cool stuff. I mean, give us your opinion.
For sure.
Yeah.
For sure. Well, periodontally, we ultimately want to keep the teeth centered in the bone because the bone is the scaffold for the soft tissue. And so by growing and developing the bone instead of just pushing the teeth out, we just have better stability long term. And so helping prevent problems, helping improve stability, improve our outcomes, and really helping. And I think also the airway implications are phenomenal. We're seeing improved nasal breathing. We're seeing improved tongue space. And we see a reduction in the sleep apnea scores.
Yeah.
Once again, we cannot promise resolution of sleep apnea. And that's another big piece. We do a lot of education with our patients, talking about what's reasonable to predict, what's a reasonable expectation, rather than promising something like a cure, which we can't make that promise.
Yeah. And wouldn't you agree? Like, this is a very exciting time to be a dentist talking about these subjects. And I think it's becoming more acceptable as a public to talk about these things. I'll just take you on my journey. Like, I'm a constant dental project in the works. I actually have to come see you. I've been through ortho 3 times. I have the CPAP, Jeff Rouse, and we won't get it in my case, but like the CPAP joke is a big one. Like we can't go, So my point is, like, people are talking about it more. Now they're talking about kids. The conversation, even about 7-year-olds, 8-year-olds, 10-year-olds not able to breathe, I'll hear it at the ballpark. I'm like, wow, like people are actually talking about this and they're much more knowledgeable. So it's like the perfect time to lean into this, don't you think?
Yes. Orthodontics isn't just about straight teeth anymore. We, as a dental profession, have the ability to make patients healthier.
Yeah.
And that is a privilege.
It's a huge privilege. All right, so you're going to problem solve for us today because you mentioned CE junkie. Now, we have a ton of them on here. I'm a recovering CE junkie. That's why I actually do the podcast, because it's my outlet. But here's one of the challenges a lot of people have, and maybe you as the listener have this. You're a 32-year-old dentist. You love CE. You're on fire. You're taking all these courses. You've actually seen Becca speak, and you're like, I love this. But Becca, I go back to my town, and it's like no one wants to hear this. I get this question all the time. How do I get my supportive dental community to learn about this, buy into this? Any insight? Like help the dentist who really wants to do this but doesn't have the community buying into this.
For sure. I think if you can travel with any of your team to courses together, that becomes really powerful. And so that you can all speak the same language, you have the same goals, whatever courses you may take to travel with your team. And I'm happy to make some recommendations of courses to go to. I think also just genuinely taking the time to meet together, have coffee together, invite some of your professionals or colleagues to your office, look at cases together, have some literature, some papers, and say, hey, this is something I saw. What do you think about this? Can we talk through this? So that we're all talking using some of the same language and the same goals.
Yeah. Now, another thing too, I'm going to keep you on for a while because these are the stories I hear, is that once you find your passion in dentistry, how you want to serve patients, the thing that often isn't talked about that's a huge benefit is that you start solving one problem like this, then a second one, a third one. You have people now that start coming to you because you solve this problem. It's amazing that people come into your office, sit in the chair and say, I want a MARPE. And you're like, where did you come from? Type of a thing. We hear this from young dentists that are passionate about it. But when you solve problems, they send other people that want you to solve their problem. Do you agree with that?
100%. Yes. And I think also if you can help identify for a patient the problem that they may or may not be able to articulate, and you then can provide a solution, then you're providing a fantastic service for them. And then I think also case acceptance goes up.
Yeah, I love it. I love it. So I do want you to share your course because you have an amazing course coming up on September 25th and 27th, and then any other courses you recommend. But before we do that, give us some final thoughts on this, Becca.
Final thoughts. It's an exciting time to be a dentist. Like you said, Kirk, it is such an exciting time to be in this profession because we really can help these patients get healthier. It's not just about cleanings and fillings and crowns. In orthodontia, it's not just about straightening teeth anymore. We can look at the whole system. We can look at the periodontium. We can look at the tongue. We can look at the nasal breathing. We can work collaboratively with our ENTs and our sleep physicians and talk about sleep. And MARPEs is helping us. It's providing a tool for us to truly, no pun intended, but to expand the type of services that we can provide. So MARPEs has been an absolute game changer for our practice. And to be able to do it with a great degree of predictability and to be able to do it without surgery has transformed our practice in such an exciting way.
Yeah. And this phenomenon in dentistry is not going away. It's not drying up. Would you agree?
Oh, it is exploding.
Yeah.
It is exploding. Absolutely.
Yeah. All right. Well, I want you to share with our listeners the course. No, first of all, I know a lot of people that are listening to this are going to want to know more about you. And I'm going to say this to you if you're listening. If you have a study club and you have not had Becca speak to it, what are you thinking? Like, she's amazing. Do it right now. Reach out to her and get her to speak to your study club because it'll blow your study club away. But I want people to know, how do I find out more about you? And then also tell us about the course.
Absolutely. Well, Mike Gunson is an oral surgeon in Santa Barbara, and the two of us love to teach together. So we put together our course. It's called Healthy Growth, Healthy Faces. And it's truly a continuum. So we start with growth and development. And so there's a lot of information about what do we look at in the growing child. And then ultimately looking from birth to old age and everything in between. We talk about lips, we talk about speech, sleep for sure, jaw surgery, TAD expanders, joints. We look at everything, and it's a very all-inclusive 3 days of learning, and it's great for the interdisciplinary team. So pediatric dentists come, periodontists, oral surgeons, for sure, restorative dentists, orthodontists. We sometimes have speech and language pathologists, mouthfunctional therapists, ENTs, sleep physicians. We've even had plastic surgeons come. And so it's not just a great place to be a student, but also to be collaborative and just to hear everyone, even in the Q&As and in the happy hours, just learning from each other. It's just a fantastic course.
Yeah. And then it's in Kirkland, Washington, right?
Yep. Kirkland's just right outside of Seattle on the water outside of Marina. It's a beautiful location. That's
awesome. So we're going to put, if you're not taking notes, we take notes for you. So if you're listening to this in the car, don't look at your phone just yet. But when you're parked, you can flip up to the show notes right below. We've taken notes on everything Becca has shared, and you're going to see a link at the top for the course. Just do yourself a favor. Click the link, attend the course. I promise you, you will absolutely love it. So it's great stuff. Becca, thank you as always. I'm going to have you back again and again and again. I just always love having you on the show.
Thank you for the invitation, truly. And thanks for all you're doing, Kirk.
I appreciate it. Well, stick around while we say goodbye to everybody else. But thank you guys for listening to the Best Practices Show podcast. I don't know how this is working. I don't know how it's happening. But you guys keep sharing this information with your friends, your colleagues, and we'll keep bringing it. Make sure you check out Becca's course. Again, it's down in the show notes. We make it easy for you. You can just click the link and learn more. I promise you, you'll absolutely enjoy it. Keep sending us suggestions for things you guys want to see. You're going to see we have an amazing lineup all through this summer. And until we see you guys next time or you hear from us next time, keep watching or keep listening to the Best Practices Show. You guys enjoy your day.